Welcome to Module 7 of Mechanical Ventilation Basics, where we will delve into the unique features of the AI-powered Ventilation Mode Adaptive Support Ventilation, ASV. ASV is a highly sophisticated, advanced closed-loop ventilation mode distinguished by its ease of use, continuous monitoring, and self-adjustment of parameters based on patient feedback. This unique feature allows ASV to strive for an optimal breathing pattern based on the principle of the lowest work of breathing and minimal force of breathing, keeping airway and driving pressures low. First introduced in 1998, ASV is proven to apply and maintain an effective lung protective strategy and expedite recovery times. ASV benefits patients and clinicians by enhancing patient safety, optimizing care delivery efficiency, reducing the cognitive burden on healthcare providers, and empowering clinicians to make precise and timely decisions. The key to ASV's success lies in its real-time adaptability, which allows it to continually monitor patients and adapt ventilation parameters, promptly responding to patient conditions and potentially improving outcomes. This adaptability also makes ASV an excellent tool for teaching ventilation principles. Providers can monitor ASV's ventilation decisions and relate the settings and changes to the patient's evolving condition and lung mechanics. One mode, simplified controls, and adaptability. Adaptive support ventilation is the mode we'll utilize for all patients intubated in the field following medication-facilitated airway management and spontaneously breathing patients after crash intubation or for transport out of a facility with patients on mechanical ventilators. ASV's three primary goals exemplify the individualization of ventilator settings, empowering healthcare providers to tailor the settings to each patient's unique needs. It offers one ventilation mode for all patients, whether actively breathing after crash intubation or passively breathing following MFAM. ASV simplifies the process of ventilation with its straightforward approach. It offers only three main parameter controls: percent minute volume, PEEP, and FiO2. This simplicity allows healthcare providers to feel confident and at ease with its use, knowing they can easily navigate and adjust these controls to suit the patient's needs. ASV enhances the physiological aspect of ventilation by automatically selecting the breathing pattern and continuously adapting to changes in lung function on a breath-by-breath basis. This adaptability reassures healthcare providers that ASV is constantly monitoring and adjusting to the patient's condition, providing a secure and reliable method of patient care. Understanding the impact of ASV's parameter controls on patient outcomes is crucial for effectively utilizing ASV. The percent minute volume, one of ASV's main parameter controls, directly affects CO2 elimination, while PEEP and FiO2, the other two primary controls, influence oxygenation. You are familiar with the concepts of setting PEEP and FiO2. Set the PEEP and FiO2 according to objective patient data, medical presentation, and clinical judgment. Later in the presentation, we will discuss the specifics of working with these settings in adaptive support ventilation. Minute volume is normalized to the ideal body weight. 100% minute volume equals the basal ventilation requirements for a healthy patient at rest, with normocapnia, with normal metabolism, and normal lung function. For patients over 30 kilograms, the basal ventilation requirement is 100 milliliters per minute per kilogram of ideal body weight. For example, if the patient has an ideal body weight of 75 kilograms, with the percent minute volume set to 100%, ASV creates a target minute ventilation of 7.5 liters a minute. Is the percent minute volume always 100? The answer is no, but you'll see it makes sense. Clarity on the functionality of the percent minute volume helps with grasping its purpose. Generally, an increase in the percent minute volume increases minute ventilation, decreasing the end tidal CO2. Conversely, lowering the percent minute volume decreases minute ventilation and increases the end tidal CO2. In the ASV control window, there are two secondary control parameters to be familiar with: P-limit and flow trigger. P-limit is the maximum peak pressure limit set by ASV. Remember, a blue line on the pressure waveform indicates this. The default is 30 centimeters of water, which requires adjustment only if the patient has high airway pressures. How will you know when to adjust the P-limit? The ventilator will warn you that ASV cannot meet the target. Raise the P-limit by 5 centimeters of water or the amount to reach the ASV target. Adjusting the P-limit will also change the high-pressure alarm limit and vice versa. The high-pressure alarm limit must remain at least 10 centimeters of water above the P-limit, or an alarm will warn of a pressure limitation. An example is a patient with stiff lungs and decreased lung or chest wall compliance, such as ARDS, atelectasis, pulmonary fibrosis, increased abdominal pressure, or kyphoscoliosis. The flow trigger is the other control parameter that infrequently requires adjustment in ASV. The flow trigger determines how sensitive the ventilator is to a patient's attempt to trigger a breath. The default setting is 5 liters per minute. The patient must generate at least 5 liters per minute of inspiratory flow to trigger a breath. Most patients we transport will be apneic on pulse oximetry and end tidal CO2, so we will know they are oxygenating and ventilating effectively, but unable to trigger breaths. So, how does an apneic patient trigger a breath? Well, they don't, but something else might. It's scenario time. So you're bouncing down a pothole-laden road and notice extra breaths triggered by the bumps and vibration. Since the patient is not breathing, the ventilator supplies the patient's total metabolic requirement for oxygenation and ventilation. Therefore, the flow trigger is safely increased incrementally by 5 liters per minute until the unintended breaths stop.